Welcome to Behind the Red Line video edition. And today my guest is Brian Dawson, the System VP over CommonSpirit of Surgical Services. And welcome, Brian Dawson.
Well, thank you very much, Josiah.
Brian, I'm thrilled to have you here, and we have a exciting piece of news to get to towards the end of our conversation together. But we've known you for a long time, but let's assume that not everyone knows you and begin with a round of introductions. Brian, tell me a little bit about your role at CommonSpirit. I'd like to hear, I think the audience would like to know your scope, and however you want to measure that, hospitals, ORs, case volume, employees.
Right.
So why don't we go ahead and let you give us a little bit of introduction as to your role at CommonSpirit.
Right. Well, first of all, I'm sure that not many people have heard of CommonSpirit. We are a Catholic health system that brought two fairly large Catholic health systems together. Dignity Health in California, Arizona, and Nevada, and Catholic Health Initiative that has facilities in the Pacific Northwest, Texas, the Midwest, South Dakota, Kentucky, Tennessee. You can see where I'm going. We merged about 2 years ago to form CommonSpirit. And our system is evolving just recently. In the state of Colorado, the Centera hospitals, which used to be a joint venture, are now part of our system as a whole. So we have about, I would say 160 hospitals. We also have extended, health facilities for older people. But I'm really over as the system leader of all of the operating rooms in our system. I'm the conduit between the hospitals and the division leadership and the system. So I coordinate everything from standards of practice, capital equipment, productivity, you name it. If it's perioperative, it kind of comes through me. And I'm the hospital's advocate with our executive leadership.
And I know that your role is about the system and about aligning these operations, this capital equipment across these multiple sites. I think that's a fascinating career. I think that the director of surgical services that wants to ascend up in the org chart has this system idea of a role, as opposed to just going to become a chief nursing officer or even a CEO. But you've been that too, right, Brian? You were also the director of surgical services years ago, and that's where you sort of cut your teeth, so to speak.
Right. So I started my career, back in 1983 as a staff nurse in the Navy. And I progressed through the Navy ranks from, staff nurse to, director to division person. And then I shifted into other aspects of healthcare, quality, patient safety. I became a hospital COO, a hospital president, a division leader, and then I had the chief of staff job to the Navy Surgeon General. I retired in 2010, kind of went backwards. We met when I started working at Salem as the vice president of perioperative services. I went from there to a facility here in Colorado. I started doing some consulting. We worked together again with Sutter, and did some work through B.E. Smith. And then I found this role with Dignity. And like you said, it was that next level up of OR leader that reported to the chief nurse of a system. And I went that direction to kind of coordinate all of the perioperative things, if you would, for a system and interact with the system chief nurse, the system finance officer, the system COO, system CIO, and really kind of coordinate all of those entities. Because, as you know, and those who will listen to this interview, surgical services or procedural areas is where we really generate our revenue. And I've found, and other systems are doing the same, are finding that having someone like this in my role helps them move those things forward.
Those are great comments. I can't wait to talk about the revenue driven by surgical services and what you're experiencing right now. If we can go back to one thing, so there are so many systems that have 4 facilities, 8 facilities, 10 facilities, and that person's job changes. They have maybe a main office in the flagship. They're maybe driving to the different facilities. They're maybe having hotel offices, but that's not even you, because you have dozens of facilities. Can you give us kind of a day in the life when you don't have, when it may be hard for you to remember the names of all the directors of surgical services who come knocking on your door, asking for resources, asking for guidance, asking for best practices?
And so, prior to COVID, I was that person on a plane every other week, literally flying around the country, because I felt it was important for the leaders to know me, know the face. When you email Brian Dawson, you know who you're getting. And so I built those relationships over the first 2 or 3 years that I was in this role. Now that we're 5 years in, one of the things that I do is there's a ton of work that gets done through Zoom and through emails. Literally, I must get 150, 200 interactions, whether they be on the phone, whether they be through Zoom, whether they be through an email, every day, that run the gamut from soup to nuts. Because anyone who has any questions about perioperative services is going to reach out to a single entity, me. And so I literally, before we got on this call, I got an email, an instant text through our email system from a business person in the Pacific Northwest that says, Brian, how do I know in Epic if a case was scheduled as an elective case or an add-on? So because I know all of the contacts, I said, well, this is how you'd know, and reach out to this guy in the Pacific Northwest because he coordinates all of the surgical things, and he'll show you in Uptime how to do it and how to run a report. And so I've got one person who helps me. She's one of my business analysts. And so between the two of us, we literally herd all the cats.
Right. At your level, you have enough infrastructure that your job is to sort of point people in the right direction to get some of their resources in.
Right. And Josiah, we built a structure to where in our divisions, we have people who are mini-me's. And so we have a council meeting every month that brings together all of those individuals who are voting members. And then we have multiple sub committees, SPD, OR scheduling, IT, you name it, and we coordinate all of those groups which disseminate information and bring us information.
Great, that's really insightful. Let's talk a little bit about what you're experiencing today in surgical services. I feel like there is some pressure, probably is, I think, where we're going to say that we have a consistency with the economy overall. But to what degree, how would you characterize the state of the surgical services economy today? How is it similar from that which we read about in the Wall Street Journal, and how is it different?
In a lot of ways, how a surgical services department or procedural department, and I say procedural because I'm putting cath lab, IR, endoscopy in that group. We've seen a major drop in inpatient surgery. So a lot of things are moving to surgery centers.
Okay.
So 10 years ago, this was something that I really pushed leaders to invest in, whether it's a surgery center that's part of the hospital or the hospital owns, because we knew that a lot of same-day surgery, laparoscopic, some robotics, big-time orthopedics was going to be moving into that realm. So we've seen our volume in our inpatient tertiary facilities drop. As a result of that, revenues dropped. One of the things that we've tried to do is take advantage of the capacity our ORs have. So we're using, the latest AI to look at what surgeons aren't using their block time, how do they release it, and how do we market that to bring in new business? And it's paid dividends. Those who are using those tools well have brought in new business and increased their contribution margin. And so we've now embarked on a 6-month challenge to use AI to see who can grow their business. So we're looking at staff room utilization numbers, we're looking at block utilization numbers, we're looking at volume, but we're looking at a category that we called release fill rate. How well are we releasing unused time and filling it? And so we're trying to think of everything under the sun to help grow our volume, because as you know, and anyone who reads Becker's, large healthcare organizations, regardless of who they might be, whether it's us, Kaiser, HCA, Mayo, Cleveland, Hopkins, you name it, we're all losing money because that dollar that we used to get from the federal government is now about 75, 65 cents. On top of, we're all faced with vendors increasing cost, increasing consumable pricing, increasing capital equipment pricing. I'm thinking of things like robots, fracture tables, OR lights and booms, because those companies are suffering as well. So when you get, $1,000 to do a procedure and it costs you $1,200 to do it, you're losing money.
Right.
Whether that $1,200 is what you get in reimbursement or what the vendor has raised their price. So there are a lot of things we have to be aware of to keep costs down, improve efficiency, and grow our volume, on top of what I think is our biggest crisis, and that's manpower.
Okay, let's talk about that, because your release fill rate, by the way, that by itself is a great insight. And I'm reminded of my conversation with a surgeon who said the recession's already come for surgeons because we can't get our cases because we don't have staff.
Correct. And what I think is one of those of quiet impacts of COVID. Everybody saw, elective volume dropped, hospitals were all in extremis. We got a lot of government support, which helped us get through it, but then that COVID support stopped. The problem was when we stopped doing procedures, a lot of facilities, I think, made the mistake of closing ORs and furloughing staff. In other words, there's no volume, I don't need all the staff, so I'm going to call people off. And as a result, a lot of nurses left nursing, periop nurses. The problem we have now is, how do we find trained, qualified nurses, but more so technologists? Because those school training programs have shrunk nationally. And then the other bad part is we're aging out of the workforce. And so, like you said, when I said staff room utilization, I might have 10 rooms in a facility, but I'm only running 6 because I can only staff 6. And the other big hit we took, anesthesia support. A lot of the mom and pop anesthesia groups that we worked with at our various hospitals have gone away to larger groups that are supported by hedge funds, and they're starting to tighten the screws because the money generation pre-COVID isn't there any longer. So those groups have shrunk. We're looking at hiring anesthesiologists and moving away from the model where we employ small groups. And to do that, it's going to take support from our larger systems. It's going to take the evidence we can grow our volume before we bring in that staff to support potential future volume. but we have to bring that staff in ahead of time.
Great.
That's our biggest challenge nationally.
Is that right? Okay. Yeah. Yeah. So let's talk about the big exciting news. So Brian, are you going to be making any major changes in your professional career this fall?
Yes. And it was a nice build-up. So I am going to be retiring from this role, and moving to potentially moving to Florida. I will still consult, work with individuals like yourself. I'll still do work for some of the organizations that I've been part of. I'm a board member on a couple of boards, and so I enjoy doing that. I've been speaking nationally, and so gonna step away from the day-to-day work, spend more time with the grandchildren and the children, and after doing this for over 40 years and at 63, it's time now to take a little break.
Wow, that's congratulations! What a wonderful career you've had. You had a wonderful career up to 2010, and then you took it and opened up a new chapter. So I'm so proud to have had a relationship with you for the last 15 years. Let's go to go ahead and let's give a plug now to Brian Dawson Consulting LLC. Why should a hospital CEO hire Brian Dawson Consulting LLC come November of this year?
So it's so let me give you the company name. It's BD Perioperative and Healthcare Consulting LLC, but it's me, right? Right. And so, the one thing that I have brought already to facilities, and I believe I could, is that complete A to Z consulting. Unfortunately, with a lot of the white glove consulting companies, Deloitte, McKinsey, some of the others, they'll bring in a bunch of young kids who are very excited with an idea. And what I feel is lacking is the understanding of the perioperative environment from the leadership level and from the ground level, and how to execute and achieve results. And part of that is building a team around the result you're looking for. That team consists of your own staff. And I've been lucky enough to be trained through the military to build teams and lead them to achievements. And we've been, successful. I know enough subject matter experts to bring in the IT people and the SPD folks or the quality people, and we don't break the bank. And so as a result, I felt we brought a very good outcome to Sutter when you and I worked together. To USC, we expanded their surgical capabilities, opened up a outpatient surgery center for orthopedics in one of the structures there at USC, and programs thriving. And so those are the types of things that I think I could bring to the table. So wonderful. We'll see.
Wonderful. I'm certain that you'll be fine in terms of you'll have more work than you'll be wanting to balance with your
exactly
with your retirement. How do you want to be remembered? What's going to be the Brian Dawson legacy?
I hope to be remembered as a leader, as someone who was straightforward and honest, and someone who understood what it is to be in an OR room as a staff nurse, to be an OR leader, but also to sit in the hospital president's seat and to bring all that together around perioperative services. And be able to provide the needed care to the communities that we serve. I'm ecstatic that I had a chance to work for CommonSpirit, because our facilities are in inner city areas, and we have a ton of critical access hospitals in farm communities. And so we're still serving, those missions that the nuns set up back in the 1920s. And I'm happy that there are still organizations that focus on providing care to those who are in need, of diverse populations, whether they be minority or farmers, because I think sometimes both sections get forgotten. So I'd like to be remembered for supporting that.
All right, that's terrific. Congratulations on a career well worked and a life well spent.
Well, thank you very much, Josiah. And I look forward to us still working together.
Yes, yes, of course. All right, well, thank you very much to Brian Dawson and CommonSpirit, and keep up the great work.
Great, thank you so much.